really go through this very quickly so that you all can get out of here somewhat on time. What I learned as a fellow, and what was very important to me in this field of vascular anomalies, was basically that I needed to call things by the right name. So there's a Chinese proverb that says the beginning of wisdom is calling things by their right name. And a very astute plastic surgeon who got me involved in all of this from Boston actually helped me with that. And he was the one, his name is John Mulliken, who back in 1982, he sat down with a couple of his friends and he said, we need a classification system for vascular anomalies. And so it was very simply, they're either tumors because they're growing and proliferating, or they're malformations because they're present at birth and they don't really do much of anything. But we know that that's not true. And there's a group called the International Society for the Study of Vascular Anomalies. And what they did is they took this classification, and over the years they've been changing and expanding that classification. So we have added new diagnoses. We've also added some genomic information. So now we have phenotypes that we can link to genotypes. In 2014, the Scientific Committee of ISFA redid the classification, and that was published, and I was lucky enough to be part of that. And in 2018, we did a classification as well. And at the next meeting of ISFA, we're going to sit down and have a day session on how we even need to improve that. So if anyone is taking care of a vascular anomaly patient and they're unsure what the diagnosis is, first of all, we're all there to help. So anyone can call any of the specialists, because we have groups all over that are part of the vascular anomaly SIG. But you can go to the website for ISFA, and on the front page of the website is a spot that says classification, and you can open it up. And this one-page classification is now almost 20 pages. So let's talk a little bit about vascular tumors. And vascular tumors are tumors, and they are stratified in WHO, and they're also stratified in ISFA to be broken down into benign tumors, tumors of intermediate aggressiveness, and borderline tumors such as caposiform hemangioendotheliomas, and then the malignant tumors that we take care of like epithelioid hemangioendothelioma or angiosarcoma, which you're going to be seeing in the solid tumor world. And I think that's really important because these are diagnoses that are related to oncology. And a lot of the genomic information we're finding are somatic mutations that we see in a lot of solid tumors. So the most common kind of tumor, and it's the benign tumor, is a hemangioma. And when we say hemangioma, we truly mean infantile hemangiomas. So these are pictures of infantile hemangiomas. And you see that they're all different. This is a pedunculated hemangioma. This is a deep hemangioma. This is a segmental hemangioma. This is actually not an infantile hemangioma, but it's a congenital hemangioma. Does everybody do it? Is my pointer on there? I can't tell. No, okay. So the congenital hemangioma is the person who's the bottom on the left, and then the others are the pedunculated is right on top, the deep is in the middle, the segmental is all the way over on the side, and then you can have mixed lesions. And the lesion that's on the bottom all the way to the left was actually thought to be a solid tumor. So that baby almost went for a biopsy. And they talked to me about the child. It was warm, there was a little blue U, we did an ultrasound, and the ultrasound was characteristic for a hemangioma. So we know a lot about the epidemiology of hemangiomas because the dermatologists have looked at that. There's a group called the Hemangioma Investigator Group that actually has looked at the epidemiology of hemangiomas. We know that they're more common in females than in males, and you probably will have a question about hemangiomas. You probably have a case of a hemangioma, and probably you'll see a picture of one. And that case will talk about how that child presented. So that lesion, that skin lesion, was not present at birth. It grew afterwards. It probably was a female infant, or it could have been a twin because they're more common in multiple pregnancies. They're also more common in premature babies because we think that probably placental issues have a higher risk of having hemangiomas. We do know that the hemangioma endothelial cell is a clonal cell. So there's a lot of information that we know about hemangiomas, but then there's a lot that we don't because we still don't have any genomic etiology for this. A lot of the basic scientists feel that perhaps it is a rescue. So there was an area of hypoxia, and the hemangioma happened because the hemangioma is rescuing that area of hypoxia because Notch signaling is there and other nitric. So there's a lot of other things that are in that area that makes one think that, but there's a lot we don't know. So this is a typical diagram that tells you the natural course of a hemangioma. So you see the hemangioma is not present at birth. Oh, so the hemangioma is not present, and that's not great either. Well, it's not present at birth, and then at days or 2 to 3 weeks of life, it starts to grow, and that proliferative period happens for about 6 months, and then it stabilizes, and then it involutes. And so the involution period of that hemangioma lasts 3.5 years. So by 3.5 years, the active hemangioma is gone. You might have some residual changes there to the skin, but the hemangioma is gone. And so I'll give you an example of a patient that we saw just last week at Boston Children's Hospital. We had a baby that prenatally was diagnosed with a brainstem tumor. And the baby was born and at 8 days had symptoms that were secondary to the brainstem tumor. On imaging, it looked like a benign tumor, but a vascular tumor, and so they did a biopsy of this tumor. And the biopsy showed some vessels, not a lot of proliferation, and the biopsy was called by the neuropathologist an infantile hemangioma. So you can see from what I told you is that's not right? Because infantile hemangiomas are not present at birth, they're not seen in utero, and they grow. So when you have a biopsy of a hemangioma in the, when it's growing, you will see MIB1 that's very high. There's a lot of turnover of cells, and they're nice, plump, normal endothelial cells. So we knew right when we heard the history that that was not a hemangioma, and it wound up being something called a hemangioblastoma. So hemangiomas also have a very characteristic picture on ultrasound. So they are high flow, they're capillaries. So they're connection between the smallest arteries and the smallest veins. So they feel warm, they feel firm, just like a mass. But if you put an ultrasound probe on them, they're high flow. And so for those hemangiomas that are deep, all you have to do is put an ultrasound on them. There are other reasons why you need to do MRI imaging, but for the most part, MRI should not be part of your diagnostic workup for a hemangioma. We also know that hemangiomas under the microscope stain positive for a glucose transporter immunostain called GLUT1, and this might be on the boards because this is very characteristic for infantile hemangiomas. There's something called congenital hemangiomas, and they are GLUT1 negative. The one thing that you have to be careful about is that angiosarcomas in 20% of the time can also be GLUT1 positive. So remember, you need to look at the history, you need to look at what the infant looks like and what the imaging is to help you sort of make this diagnosis. But in every stage of that development of the hemangioma, they are always GLUT1 positive. So this has been a great advance for us. We know that hemangiomas have associated syndromes, and this is probably not going to be on the boards for right now, but important for you to know as you're taking care of hemangiomas. And I know a lot of dermatologists take care of hemangiomas, but in smaller places and even larger places, hematologists, oncologists will be taking care of them. So one of the common syndromes is when you have a segmental hemangioma that's in a beard distribution. So this is very simple. So the hemangioma is kind of over a bearded area. So, this is part of your beard, and the more parts to the beard that are involved, the higher risk of that patient having an airway lesion. This is not a contiguous lesion. This is a separate lesion. It is usually in the subglottal area. And you do not want to wait for someone to have symptoms in order for that to be evaluated. So a lot of vascular anomaly centers will actually have ORL or ENT people as part of their clinic. And if there's a hemangioma in a bearded distribution, an ORL or ENT person will come and scope that person right in clinic. And if there is a hemangioma, that patient will be started on therapy right away. You guys have probably all heard about multiple cutaneous hemangiomas. So we think of, in the past, this used to be called hemangiomatosis. If you go into the literature, hemangiomatosis is really a horrible word, and basically there are many degrees. There's a lot of heterogeneity with multiple hemangiomas. We usually will look at the liver in someone that has more than 5 hemangiomas. Hemangiomas can be in other places, such as the spleen, the lung, the GI tract, but they're so rare and you truly don't have to look at them. So if you have 5 or more hemangiomas, the only place that you really need to look at is the liver, and that actually might be a board question. I want to talk a little bit about liver lesions because this is really important, because liver lesions can be characterized and divided as well. And this is very important for particularly oncologists to look at this, because they can be divided into focal lesions, multiple lesions, and diffuse lesions. And a single lesion that looks like a vascular lesion is not usually an infantile hemangioma. It's usually a congenital hemangioma. We're going to talk about congenital hemangiomas in the next couple of slides, but congenital hemangiomas are hemangiomas that develop in utero, and you are born with them fully developed. And has anybody actually seen a congenital hemangioma? They can be very, very scary. The child can have a mild coagulopathy, and we're going to talk about that a little bit, and that is something that also might be on the boards. So might have a transient low platelet count and a low fibrinogen count. But these lesions versus hemangiomas, infantile hemangiomas that go away by the time someone is 3.5 years of age, congenital hemangiomas, if they rapidly involute, can go away by the time someone is 15 months of age. So usually, and they can't, and they cannot be treated with propranolol. Propranolol doesn't really do anything. They get better on their own. So supportive care is what you need to give those patients. Versus multiple hemangiomas, if you have a couple of hemangiomas in the liver, those are probably infantile hemangiomas. And diffuse hemangiomas is that the hemangioma takes up almost all of the liver parenchyma. And those are usually infantile hemangiomas as well. This is a patient that presented when I was a fellow, and I would go up to Boston to learn more about vascular anomalies, and this infant presented with an enlarging abdomen and actually had compartment syndrome, and unfortunately this infant wound up dying of heart failure and other things. But this is what the scans looked like. And you can see that this is a diffuse hemangioma. These are vascular lesions, so they have enhancement periphery around the outside, and the center is not enhanced, and this is a classic picture of what they look like. But it is so very, very important, if you have even the multiple lesions, to get these looked at by a musculoskeletal or other radiologist that knows what a vascular lesion looks like. And you think about other things as well, because we know that sometimes hepatoblastoma can be have multiple lesions and be vascular. And you certainly don't want to miss a neuroblastoma. But this is a very classic look for a diffuse hemangioma. The other thing that can be secondary to diffuse hemangiomas is hypothyroidism. And hypothyroidism is so significant that it can cause heart failure. And it's because these tumors are rapidly proliferating. This happens only in the liver, which is very interesting. And functionally, there was an endocrinologist that actually took this infant and figured out what the issues were. So the active T4 and T3 is degraded by type 3 deiodinase enzyme. And so whenever you see a patient that has multiple hemangiomas in the liver, you always have to check thyroid hormone and thyroid function. There's another syndrome that's associated with hemangiomas. It's called FACE syndrome. How many have heard about FACE syndrome? So the P stands for posterior fossa abnormalities, but it also can be secondary to other CNS issues The H stands for a hemangioma, and they're usually segmental hemangiomas. The A stands for arterial issues, so you can have absent CNS arteries. So I had a patient that had an absent vertebral artery and also an absent carotid artery. You can have heart anomalies, and the most common is coarctation of the aorta. Eye anomalies, again, not from the hemangioma, but so agenesis of the optic nerve is something that people can have. So these patients really have to go through sort of a strict workup, and this is probably one of the only reasons why you would do an MRI on a hemangioma to look, and so you would need an MRI and an MRA for this patient to look at the arterial issues. This is a patient that actually came to see me when I was in Cincinnati. And as you see from the top picture, a very, very astute pediatrician said, boy, this looks like a hemangioma. So this patient had went to another pediatrician who thought it was a capillary malformation. So you see on the cheeks, there's some telangiectasias. But on the lip, it looks very much like a hemangioma, and that was proliferating. And this pediatrician went to the literature and found that bearded distribution hemangiomas had an increased risk for airway lesions, and then he found that segmental hemangiomas have an increased risk for face syndrome. So he did a whole face and a whole ENT workup. This poor patient wound up having an airway lesion, but also wound up having face. And this is the infant I was talking about that had an absent vertebral artery and a carotid artery that you see on the angiogram, that one side is really blank, and had a very significant coarctation. So if you look at the picture of the arteriogram, you see how the area up above at the coarc is all narrowed, and there's redundancy of that whole arch and actually the whole aorta. That child's doing very well. So that child was initially sent home from another institution for palliative care because they weren't sure what to do for that baby, and actually came to Cincinnati and had her heart repaired, and we did other things with her hemangioma. She also wound up having a mesenteric hemangioma and was having bloody stools, and that's how that was picked up. There's also an association called pelvic and lumbar syndrome, which is the same thing, a segmental hemangioma that's now in the GU area. And for these patients, you truly do need to look, just like facies, you need to do an MRI of these patients because they can have absent iliac arteries, they can have GU abnormalities, they can have tethered cords. So very important to know what the associations are of those syndromes as well. But I don't think yet any of that will be on the boards. In the future, those things probably will be. This is that variation of hemangioma that we were talking about, the congenital hemangioma. So you can imagine if you're in the newborn nursery, has anyone seen a congenital hemangioma on the skin? You've seen them on the liver, but so these are pretty scary to look at. You know, you right away want to say, "Oh my God, this is a tumor." But you see that this is already starting to involute, because if you look at the center of that mass, it has necrosis and it has a dull color to it, so that's already starting to involute. What can happen with these things, though, is they can have very large venous vessels underneath the area because of the high flow. And if you have ulceration, you can have a significant issue with bleeding. So you have to be really careful with that. And you have to know that they will rapidly involute over 15 months. Sometimes they partially involute, and that's called a partially involuting hemangioma. And sometimes they don't involute, but the ones that don't involute look a little different than this. And we have found that the somatic mutation that's involved in congenital hemangiomas is a GNAC mutation. And GNAC mutations are also seen in patients that have capillary malformations. They also have a consumptive coagulopathy, which we talked about. So when you see patients like this, you need to check a CBC and you need to check their fibrinogen, and you need to support them through that because usually it recovers in a couple of weeks. The liver lesions can be very tricky. So they also can have heart failure because of the high flow. And the coagulopathy issue might be a question on the boards. I put this in just so that you can see. So this is one of the first congenital hemangiomas that I saw, and I was a disbeliever. Like the surgeons were telling me, "Don't worry, it's not a tumor. It'll be just fine." And you see over time, it decreased in size. There's still residual disease that's there, but the active part of the hemangioma is not there. This is a rapidly involuting congenital hemangioma of the liver. So this is an X-ray where you see an enlarged liver. So these children really do have pretty significant livers. Remember, we talked about the chance of bleeding. So these liver lesions can bleed as well. And so these congenital hemangiomas should not grow in size. If they grow in size, you really should do a CBC and make sure there's no bleeding into the lesion. Because if that's the case, whenever I have these, I always have the liver surgeons and the transplant team sort of available, because you want to make sure that if there is an issue that happens and it can be surgerized, then you can excise that lesion if it needs to happen. These are some other pictures of liver hemangiomas. You see the single ones, the congenital hemangiomas, look very much like the infantile hemangiomas, which are multiple. And so you need a good radiology that's helping you try to diagnose these. So what's our management and our treatment? So when we think about when do you treat a hemangioma, you know, when I started doing this, it was we did not treat a hemangioma unless we really needed to. If it was on the face, if it was interfering with vital structures, if there was ulceration. But now we know that there are really other reasons to treat because we have residual lesions and we have better medicines. So I sort of think now, when do we not treat a hemangioma? And we're trying to get pediatricians to try to use topical agents to treat hemangiomas. But we obviously treat hemangiomas if there's a risk to vital structures. Some of this might be on, because I think there could be a case scenario with this. You think about where is the hemangioma and what is special about the anatomical site. So if it's over the lip hemangiomas have a higher risk for ulceration. There's also a risk if that lip ulcerates of not being able to be fed. There's a big nutritional risk. Anything on the nose, so the nose is the center part of your body, and if you have a hemangioma that's growing on your nose, there's a pretty significant chance that that infant, if it doesn't get treated, is going to have some disfigurement and some damage to the cartilage. Obviously, we talked about segmental hemangiomas and the associated syndromes and the possibility of ulceration. Hemangiomas around the breast can absolutely cause disfigurement as that child gets older, especially if it's a female. And in the anogenital area, that's a high risk for ulceration. So those hemangiomas should be treated right away. So since you've all taken care of hemangiomas, you know propranolol, and you know the story of propranolol. So propranolol is a beta blocker that was being used in Europe. A lot of cardiologists used it sort of as a first-line medicine for cardiomyopathy. There were 2 babies that had hemangiomas that were treated almost simultaneously at different institutions. One had a hemangioma, and because of significant steroid use, had a cardiomyopathy, and that's why the baby came in for propranolol therapy. And the other one had a cardiac issue and was treated with propranolol and had a hemangioma. And after 24 to 48 hours, the mothers actually said to the physicians, look at my child's hemangioma, it looks so much better. And so those 2 institutions got together and they had, they did a series of patients and they published that in the New England Journal. And then they basically had a larger double-blind placebo-based trial. And there is now a preparation of propranolol called hemangiol that's out there, and it is FDA approved. So that's a pretty big deal. We know that propranolol is a non-selective beta blocker, and so hemangiol is too. So it's somewhat difficult to get hemangiol because propranolol is very similar to hemangiol and is a lot cheaper. So insurance companies usually don't approve the hemangiol. We think that it causes vasoconstriction. It also decreases angiogenesis. It decreases VEGF and FGF, and also causes endothelial apoptosis. But we think there's probably more to that, and hopefully at the next ISFA meeting we'll hear about that. So I don't think that will be on the boards. There probably will be a question about side effects because a lot of people ask about side effects. So one of the most common side effects that's not a significant side effect is sleep disturbances. Patients can get nightmares and irritability. They can get these other things that I'm not going to go through. Very uncommon side effects are hypoglycemia and decreased blood pressure and heart rate. Hypoglycemia can be a significant side effect, though, if patients are sleeping through the night and are not being woken, especially when they're young, to eat, or if they have a GI or a respiratory illness and they're not eating. There have been reports of people having significant hypoglycemia and basically coding, so it's not something to take lightly. Here's some contraindications, and I think you can all read that. There is topical medicine, so timolol is something that's used for glaucoma, and that is a topical or an eye drop that's a beta blocker that we can actually use on smaller hemangiomas, and it works quite well. So we're hoping to get pediatricians involved in this. There's a study now looking at sort of different concentrations of timolol. And there are other medications that are more selective beta blockers because there's a question about CNS penetrance and will this interfere? You know, these are, even though this has been around for a long time in cardiology, we're using it for a different indication, and these are younger babies. Will there be any changes in IQ points? I mean, this is going to be very hard for us to figure out, and I think this medicine is much better than giving a baby 8 to 10 months of steroids. So let's talk now about rare vascular tumors. This might pique your interest a little more than hemangiomas. So I like hemangiomas, but rare vascular tumors is really why I got involved in vascular anomalies. So we talked a little bit about the WHO classification. That classification is really not necessarily stratified for pediatric patients, and I do think that pediatric, whether it's the intermediate group patients or the higher aggressive tumors, behave differently than adult angiosarcomas, adult EHE patients. And so we really have had a difficult time trying to classify them and stratify them. But this patient is a patient, the one on the top, why I got involved in doing what I do. And the top patient was a patient that came in, and there will be a question on caposiform hemangioendothelioma on the exam. And this was a story, and so I'll give you a case study of this patient. So it was an infant who was 2 months old who had a little tiny bruise that no one even really realized on her thigh, and went in, and actually, you know, people say to me, is that a boy? Well, that's really not a boy. That's how distorted her anatomy was from her KHE lesion. So so she had her immunizations at 2 months of age, and they put the immunizations into the thigh that had the bruise. I mean, they didn't know it was a very small area. And in 24 hours, her leg looked like this. And so her platelet count was 3,000, her fibrinogen was undetectable. And thank goodness, this was in West Virginia, a very astute hemonc doctor had seen one of these in her lifetime and said, this isn't a hemangioma, because remember, these in the past used to be called hemangiomas. With the coagulopathy, which was reported by a radiologist and a pediatrician as Kasabach-Merritt syndrome. So it was a hemangioma with a coagulopathy, and the coagulopathy was called Kasabach-Merritt syndrome. And then it wasn't until 1997 that people in the vascular anomaly world said, these are not hemangiomas. These are firm, these are indurated, they're equal in both sexes. They're not as common in the head and neck. Actually, they're more common in the trunk and more common in the extremities. They're not typically in a focal area, and when they spread, they travel through tissue planes. So it's not like a regular solid tumor that destroys things in its path. This tumor sort of spreads in and around tissue planes. We talked about how the overlying skin is, and we talked about what that coagulopathy is called. And for sure, I think this will be on the test. Radiologically, again, it crosses tissue planes, so you'll see a lot of what looks like edema. There's what we call T2 intense stranding that you see. Sometimes they are what we call pedunculated, so they look more like a tumor, but more than not, they're over a more diffuse area. But lately, we've actually seen a bunch of them that have been more pedunculated, but at the bottom of that tumor, you see some high-intensity stranding. We don't usually biopsy all of them, but if there are atypical findings, and now with the question of what is the somatic mutation that causes KHE, that you can safely biopsy these. What happened in the past is that surgeons would do a biopsy that was a large biopsy like you would do for a solid tumor. And every time you aggravate these lesions, you can worsen the Kasabach-Merritt. And so people then stopped biopsying them. And I think now we're trying to re-biopsy them with a surgeon where you can go to the edge of them, take a smaller biopsy, prepare that person, with cryo and with platelets to do the biopsy. These are tumors that are made of two different things. So they have spindle cells, and those spindle cells are PROX1 positive, so that's a lymphatic and nuclear lymphatic stain. But they also are a lymphatic malformation, so they have a lot of other, and we think that basically the platelets get stuck in this very, very sticky lymphatic malformation. They never go away, so they get smaller, and even with the medicine that we have now, they never go away. And when kids go through puberty, they actually can get worse. The Kasabach-Merritt never comes back again, but they can get worse. And we've done biopsies when kids have come back later on with pain, and the lymphatic part of the tumor becomes fibrotic, so it becomes scarred. So very important if you have one of these to know that you have the diagnosis, because you don't want to, in your differential are things like fibrosarcoma. So you want a radiologist that knows how to read the MRI. You also, there's a question of, do you biopsy it or do you not? We have a tendency to biopsy a lot of our patients. And then how do we treat it? So we really don't know the best way to treat these patients. So in the past, the kitchen sink was thrown at them. So anything we were using to treat hemangiomas was thrown at them. And then any chemotherapy, because the infant wasn't getting better. I had a patient that came to see me that had 18 cycles of VAC therapy. So I'm not worried about the KHE anymore. I'm worried about, second malignancies and other things. So you have to be really careful. So our standards have been made through consensus statements. So our standards of practice now are either sirolimus or steroids and vincristine. And if a patient, we're trying to risk stratify these patients, so if a patient has a higher risk KHE, sometimes we actually use steroids, vincristine, and sirolimus. And we now have an FDA-funded study where we're looking at vincristine plus steroids versus versus sirolimus plus steroids to really see which one is better. So let's talk a little bit about sirolimus. So how many of you have treated a vascular anomaly patient with an mTOR inhibitor? Right, so a lot. So it's really one of our standards of practice now. And that came about because of that one patient, because we went through our regimen of how we typically treated a patient with KHE and everything was failing. And we thought of what potential pathway could be involved, and we came up with the PIK3CA pathway because of other vascular anomalies that had problems with the PIK3CA. And the only medicine that we had available back in 2006 was the mTOR inhibitor sirolimus. There was everolimus that was out there too, but Pfizer was more willing to give us the medicine than Novartis was. So that's how this whole deal of sirolimus came about. So now there's many, many articles on sirolimus and vascular anomalies. So now we know that sirolimus is used for all of these vascular anomalies that I have on the right, and it works probably better in the vascular anomalies that have a lymphatic component. So we know that KHE has a lymphatic component and other kinds of lymphatic anomalies. We know what the side effects are. I'm not going to get into this with you, and we've seen all of those side effects. I think we worry more about the long-term side effects because these KHE lesions particularly are, patients that are 3 years of age, and we're having a hard time getting them off because they have such a great response, and when we take them off, their lesion gets worse and they have more pain. And that's the same for the other vascular anomalies that are congenital problems, because this is going to be a lifelong medical treatment. And this is where what we typically do for KHE lesions is we treat them for 2 years and then we wean them off of the therapy. What we do for other malformations is I usually treat them for 2 years and I try to take them off of the therapy knowing that their symptoms are probably going to get worse and they're going to need to go back on treatment. So let's shift a little bit because one of the issues is the coagulopathy. So we talked about coagulopathy as it's related to tumors, particularly the KHE lesion. And there's another diagnosis called multifocal lymphangiendotheliomatosis and thrombocytopenia, it's abbreviated MLT, which is a little bit like a tumor and a little bit like a malformation. Has anybody seen, the other word for it is CAT? There's two groups that debate back and forth on what to call it. Has anyone seen this? So if you, as a hematology or an oncology, probably hematology would get this consult, get a consult of an infant that's in the hospital with pulmonary hemorrhage or GI bleeding, and really you can't figure out what the issue is, and you go and examine them, and on their exam, does everybody see that little purplish look? So that's not a hemangioma, right? That doesn't look like a hemangioma. These lesions don't grow, so when you're taking the history from the mother, she might say, well, I don't know if they were present at birth because we really weren't paying attention, but since this happened, she actually has like 5 of them that we've counted, because sometimes they're a little brighter than others, and sometimes they're darker, and they can be on the back side or where that you don't really notice. So when you're looking at that baby, look at the skin really well, because this is a diagnosis that can be incredibly devastating. So these lesions can be anywhere in the body. Usually they're in the GI tract, and usually they're in the lung, but they can be in every single organ and in the brain, and kids can die of hemorrhage. We don't really know. When you look at them under the microscope, they stain positive for something called LIV1, which is another lymphatic marker that a lot of places don't have, and they look like a very benign vascular lesion. They're not proliferating. No one understands why they are thrombocytopenic, because the vessels are so small, but you can treat them either with steroids or sirolimus has been used. And basically, by the time they're 3 years of age, they sort of grow out of the thrombocytopenia, but they'll have these lesions. And so we have not done any long-term studies to know what happens in the GI tract and what happens in the lungs. But as far as the differential diagnosis for thrombocytopenia and a vascular problem, this might be a question. And it won't be specific MLT. This will probably be in your differential, so as part of a case. So let's talk about malignant vascular tumors, because you will see these. So I think about really the 2 most common, and they're not common at all because they're very rare. So one of the things that we think about are EHE, or epithelioid hemangioendotheliomas. How many people have seen one of these? Yes, they're very, very rare, but they're out there. Usually the peak incidence is in the 4th and the 5th decade, but they do occur in young patients. I actually have a medical student that's taking all the patients with EHE that we have that are younger than 21 years and trying to, sort of look at how did they present, what was their course, what were they treated with, where are they now. This diagnosis, even though it's listed as a malignant tumor, has a lot of heterogeneity. So you can have a patient that has 1 or 2 bone lesions, and the 1 or 2 bone lesions just stay exactly how they are for 5 years, and then all of a sudden they'll start having bone pain, and now they'll not only have bone lesions, but they'll have lung lesions. And so it's very tricky. And so what I usually look at are, what are the risk factors? So do they have pain? Do they have effusions? Do they have lung lesions? Do they have lesions in other places like their brain? How many bone lesions do they have? Do they have lesions in their liver? Because there's different ways to treat them depending on where their lesions are and what their symptoms are. Sometimes they get surgery, sometimes there's surgery and radiation, sometimes they're just observed, sometimes there's some targeted therapy that's used, and sometimes you use like anti-angiogenic chemotherapy that you would use for something like an angiosarcoma. There is a CAMTA1 immunostain, and there's also a gene fusion, which is common, and that is something that you probably want to know of all the molecular things that are in vascular anomalies. I would know that. And then angiosarcomas are very rare, but the only thing that I'm going to tell you is they can be secondary to things like radiation and vinyl chloride, but when people have lymphedema and they're in their 60s and their 70s, they can get superficial angiosarcoma. We also, though, have had angiosarcoma in the liver. So remember, we talked about those diffuse lesions that look like they're vascular. We've had several patients that were 3 years of age with multiple lesions in their liver that were diagnosed as infantile hemangiomas. So you know right away, what's the problem with that? A 3-year-old should not have lesions in their liver that are infantile hemangiomas anymore. So they have to be something else. And then sometimes these angiosarcomas can actually be somewhat low grade, And remember, we talked about 20% of them can also be GLUT1 positive. So if you do a biopsy on them and they're low grade, they still might call them a hemangioma. So if you have anything like this, you need to get that patient's pathology to a vascular specialist, and also really look very closely with your team and do a good tumor board about that patient. Vascular malformations. So there's all different kinds of vascular malformations. There's so much heterogeneity. So the child that's intubated actually has a lymphatic malformation, but it's microcystic, so there's not much you can do for that patient. You can't sclerose that patient and have that be completely gone. So a lot of very invasive surgeries were done. The middle patient has a capillary malformation that did not get treated with laser and has pyogenic granulomas. The other patient with the arm has multiple venous malformations and a coagulopathy. And the patient that is the leg has a capillary lymphatic venous malformation, and then the other patient with the lip has a profound coagulopathy because of venous malformation. So I'm just quickly, I don't think you're going to have any patients, any questions on capillary malformations, but know that they are associated with something called Sturge-Weber syndrome. So if they're in the V1, V2 distribution, they can be associated with Sturge-Weber. Adrian Hamill, who's a hemonc doctor at Cincinnati Children's, is doing a study with sirolimus to help with the neurocognitive issues with Sturge-Weber. These are GNAC mutations, and aspirin is used for them, but I do not think you'll have any questions about that. So pay attention to this, because venous malformations, right? So you have venous malformations are basically very abnormal veins. You have problems with the endothelium. You have gaps in between the venous endothelial cells. You have elastic cell walls. You have decreased flow into these areas. So these lesions can cause an increased risk of clotting and an increased risk of bleeding. These are the lesions that can have really high D-dimers and really low fibrinogens. But there's degrees of their coagulopathy. And again, this is Virchow's triangle that sort of talks about, you know, why you have that. The most important thing for us to know as hematologists is why this is important. And this is important because if you have a patient that has a venous malformation and you don't know that they have a coagulopathy and they're going for surgery, and this happened to me when I was first up in Boston, and I was told, oh, don't worry about this patient. This patient had a total body venous malformation and they were doing a hernia operation. And they thought for sure that where the hernia was, there was no venous malformation. And I said, that is not true at all. So I checked his labs, and his fibrinogen was undetectable, and his D-dimer was sky high. So we gave him low molecular weight heparin to calm down what was happening at that area, the fibrinolysis, and it improved his fibrinogen, and he was able to actually have his surgery. So the vascular anomaly SIG group, this is not published. I do not think this is actually going to be on your exam, but you can look at this because this is important for you to have. Hopefully this will be published this summer. Came up with a consensus statement of who are high risk to have coagulopathy and what you do about that. And so not only was it the type of vascular malformation, what the labs were, but also it was a third thing, and that's ectasia, because a lot of these patients can have large ectatic embryonal veins that are still there that are super high risk for clotting, and that can happen in a syndrome called Clove syndrome. So I don't think you're going to have any questions on that, but it is something for you to have for your information. And then I'm going to go through lymphatic malformations very quickly. Lymphatic malformations can have their own classification. You can have lymphangiosarcomas, and you can also have different kinds of lymphatic malformations. We have simple ones, which are macro and microcystic lesions. We have more complicated lesions that can involve the bone, have effusions, involve soft tissue. Oncologists need to know about these because you might get a patient, this is a patient, a 16-year-old that came in with acute onset of shortness of breath, was seen in the emergency room and was seen to have this effusion, but also had to have bone lesions, and they thought this patient had a malignancy. But she was otherwise doing very well. She wasn't necessarily having pain. It was really just the shortness of breath from her effusion, and she wound up having a lymphatic anomaly that we call a generalized lymphatic anomaly. Gorham Stout is another type of patient that you might see. I don't think this will be on the exam yet, where you have massive osteolysis of the bones right in front. It's progressive osteolysis, and you see that this person is really losing part of those vertebral bodies, and this patient is at high risk for actually paralysis and for infection and things like that. I've had people lose their arms and lose their hip areas from this. And then there's an awful diagnosis called Kaposiform lymphangiomatosis, which is not a relatively new. It was diagnosed really in about 2014 from the people in Boston. And this is, the Kaposiform name is given to it because it has focal areas of spindle cells on pathology. But you can have diffuse channel problems, so all of your lymphatic channels are enlarged and leaky, and then you can also have soft tissue masses. This is a diagnosis that holds with it the overall survival is 34%. So this is a very significant diagnosis, and this too is part of your, if there's a coagulopathy, this might be in that differential diagnosis, because these patients can have a profound thrombocytopenia and also can have a low fibrinogen as well. This is interesting, so I just put this in for research purposes. So this is, now we're starting to do MRI lymphangiograms where you go intranodally into the inguinal nodes and you can inject contrast, and you see this patient, and it was the KHE patient, who was supposed to have a thoracic duct that you can barely see, has this very tortuous thoracic duct and significant pleural effusions that are actually bloody pleural effusions. And we're hoping with techniques like this that maybe we'll be able to do something about this, or we'll be able to do drug delivery to these areas. This is something that might be on the boards. So Clove syndrome is an overgrowth syndrome, and now we know that these overgrowth syndromes have, they're associated with PIK3CA somatic mutations, and there's something now called PROS, which is PIK3CA related overgrowth syndromes, and Cloves is part of that. Also, patients with Cloves have a slightly increased risk of Wilms tumor, not hepatoblastoma, so this very well might be on the boards. And when we talk about vascular lesions or vascular malformations in general, like what do we do? What has been used to treat them? And we talked about everything under the sun that was used for hemangiomas. So we are really trying to link the phenotype to the genotype. And it's been amazing. So when I started that first study of sirolimus, when we were really, our hypothesis was maybe the PIK3CA pathway would be involved, to know that the PIK3CA pathway is involved with not only Cloves, but 20% of venous malformations, something called FAVA, Klippel-Trenaunay syndrome, other lymphatic malformations, macrocephaly capillary malformations is just amazing. AKT is involved in Proteus. We have, P10, so hamartomatous high flow lesions that can happen with patients with P10. P10 patients can also have AVMs. We know that there are different mutations for intracranial and extracranial AVMs. And hopefully with all this information that we have, we will be able to find more medical therapy, which is the medical therapy that's actually being used for cancer, so that we can have more of an armamentarium to take care of these patients. So our future directions, we started a vascular anomaly consortium. So we do have a vascular anomaly special interest group for any of you who are interested. Vascular anomalies to me is an open page. So there's so much that we need to discover about them. And so there's a lot of opportunity for young investigators to really move forward in this. We have this special interest group. We have collaborative projects. We now have 2 studies that are open. We're hoping to have more studies open with MEK inhibitors. And then we have our consortium. So thank you very much, and good luck on your exam.